we're going to back up for just a second. I get involved in talking, I forget to advance the slides. So I just wanted to go over this slide with you. This is kind of a picture of what, especially an infant, a child younger than a year old, looks like with early signs of dehydration, moderate, and then severe. And I know the numbers on this slide are not the same as the numbers in your book, so go by the numbers in the book for that mild, moderate, and severe stage. But it kind of gives you the picture: thirst, the dry mouth, the oliguria, and the weight loss. And then for your moderate, the sunken fontanelles, the sunken eyes, the rapid deep breathing, the loss of skin elasticity. And then your severe, the rapid weak pulse, the cyanosis, and the cold limbs, which all are signs of shock, and then the coma. I just thought it kind of gave you a picture that might be easy to follow. And then here are some. Here is your skin tugger. If you pinch an infant's skin and it tints, makes a little tint there, and it doesn't return to the shape that it was before you pinched it, that's a sign of dehydration. The child on the top, you see, has the sunken eyes, and then the baby, the infant on the bottom, has the sunken fontanelles. These are all signs of dehydration and are things that should be huge red flags for you if you're caring for a child that looks like any of these things. Okay, we're kind of back on track now. So, a child over the age of 1, suitable place is probably the hand, the forearm, or the upper arm for that child or that adolescent. You always try to select the most distal site available. Start with the non-dominant side to avoid interference with self-care activities or other activities that they might enjoy doing, and then move to the dominant side if necessary. Keep in mind that as a young child that they might suck their thumb, and if they do, use the opposite side if you have to use that hand or that thumb vein or a finger or something like that. Make sure you take that into consideration. Antecubital veins are always appropriate for children. They're easy to view and palpate, but you should try to avoid them for peripheral IV. They're uncomfortable for the child, and you usually have to give them an arm board so that they can't bend their elbow. And that's the same thing with adults. If you use an AC site, you're almost always going to have to put an arm board on somebody to keep them from bending their arm, to keep that IV patent and properly working. If the patient is mobile, you might want to consider an IV site on the upper extremity so they can still get out of bed. Also, avoid trying to put it in the same arm as their identification band. If you have to use that side, put the ID band on the other arm to avoid a potential circulatory impairment. Okay. So the preferred venous access device for an infant and a young child, no matter what vein you use, is a small diameter weaned catheter, a butterfly. It's less likely to cause traumatic injury to the vein. You have to choose the needle and the catheter site based on the size of the child's veins and the type of fluid that he's receiving. You use the smallest gauge possible in the catheter and the shortest length to allow blood flow to around the catheter while the fluids are infusing. With blood and blood products, though, you have to use a larger catheter to prevent hemolysis of the red blood cells. You always explain to the child's parents what you're doing and why it's necessary. Forewarn them if you're going to use a scalp vein and that you might have to clip the child's hair so that they are prepared for that. When you explain it to the child, and you do, you give an age-appropriate explanation when the time is right. If the child is at least a month old, you lessen the anxiety, reduce the pain, and improve the compliance with therapy by applying a transdermal anesthesia cream before you ever do the venipuncture. You might also consider placing warm packs on the site for 10 minutes prior to the insertion to enhance vein dilation. EMLA cream, EMLA, is a wonderful anesthetic cream that you can use on a child before starting an IV. You may have to restrain a child to ensure that you can obtain the IV access and for the child's safety. Um, if possible, enlist the aid of a coworker and try to avoid having the parents help with the restraint. Encourage them to talk to the child and comfort him. Hold his hand, hold his head, stroke his arm, anything that gets them directly involved without them holding him down to try to give him a much more pleasurable experience. If he has a favorite toy, a blanket, a pacifier, anything that's comforting to him or her, make sure you provide that at the same time also, because it may ease their fear even more. If the child is an infant, you're going to wrap them in a blanket with the side exposed. If it's a toddler or school age, you seat yourself across from you or from your assistant's lap. You can also have them lie down in the bed or on a treatment table. You ask whoever's helping you to hold the extremity in one hand while restraining the other extremities. The assistant's hand can be used in a tourniquet while you're restraining the child if necessary. If you have to use a tourniquet to dilate the vein, make sure it's an appropriate size for that particular child. When you use a scalp vein, there's a special rubber band with a tape tab on it, and you place it above the child's eyes and ears. You make sure to check for a pulse, that you haven't tightened it too tightly. And you insert just like you would with anything else into the vein. You watch for a flashback, which confirms that you're in it. In a child, especially a dehydrated child, the flashback chamber may have minimal blood return. You advance the needle, slowly thread it into the vein. If you feel resistance, allow the child to relax for a few seconds and try again. Loosen the tourniquet, and then you attach the tubing to the hub of the catheter to begin the infusion. You make sure that the IV tubing is connected to a small volume reservoir, a volume control set with a micro drip, or an electronic refusion device with an anti-free flow feature to reduce the risk of fluid overload. I don't know in children anymore that they even allow you to free flow. I'm almost positive that a child has to have a pump now, that they don't run the risk of the child being overloaded with fluid by using a free flow anymore. Stabilizing an IV site can be tricky with peds patients. You always begin by applying a catheter securement device and taping the site as you would for an adult. You also have to make sure that the IV site is inaccessible to the child's little fingers and that the tubing is safely secured. They do make protective devices commercially that include plastic covers, fabric wraps, electric netting. You're going to electrocute them if they try to touch it. No, elastic netting. To safeguard that catheter, then you have to loop the tubing and the tape so that if it's pulled, the strain will be exerted on the tubing and not the catheter. If at all possible, you thread it through the shirt or the gown so it can't be reached, but and also prevents accidental strangulation with the tubing. On page 305, there are some interesting ways to protect it. There's the paper cup, which goes on the head, and then the stockinette, and the IV shield. And all of those things then try to protect the site so the child cannot get to the site. After you get the IV started, you have to remember to reward the preschool or school-age child with something that's age appropriate for them to show that they did a great job and that you appreciate them doing a good job. The frequency that you monitor the IV therapy for the child will depend on the condition, the age, and the reason for therapy. If they're receiving replacement fluids for dehydration, it will require continuous monitoring, whereas somebody with medication administration will require less frequent monitoring. So it depends on the age, the condition, and the reason for therapy. An IV site of an infant or toddler has to be assessed more frequently because he's more likely to dislodge the catheter than an adolescent or a school-age child that understands why it's there. when you assess a child who's giving IV therapy for dehydration, you want to compare the results with the child's baseline findings. Again, for pulse, the blood pressure, temperature, capillary refill, urine output, and laboratory results. You also have to assess peripheral pulses, skin color, and the temperature of the extremities. Any child who receives IV therapy should be weighed before fluid administration is started and then once per shift throughout the course of treatment. They'll have labs drawn to measure electrolyte levels and glucose levels if they are getting a fluid that has a glucose in it. You need to assess a child's IV site at least hourly. You're observing for any redness, any streaking, any edema, or soiled dressings. You palpate for hardening of the blood vessel and note the temperature of the surrounding tissue. You also have to assess the area above and below the insertion site. You see that the dressing and the tubing are secure to prevent the child from dislodging it or it becoming tangled in the tubing. Do not reinforce wet or soiled dressings, tapes, or protective devices. Change them if they become loose or dislodged or if there's blood or fluid leakage. Pain level must also be assessed when you are assessing an IV site. You can use the standard 0 to 10 pain scale for a child that understands that. You have the faces for a child that does not. And then you observe closely for any facial or body language reactions when you assess the site as well. If the site hurts, you tell him it's okay. Let him know that it's okay to tell you that. You should always be aware that the amount of discomfort can cause and work to minimize the pain as quickly as possible. IV lines are to be flushed after a medication delivery or at least every 8 hours to make sure it's patent and to prevent any complications. If saline flushes are ordered, make sure to use preservative-free normal saline solutions. And then, of course, always documentation. You document your findings, any interventions. Always document the child's reaction, any notation of pain, and how the patient tolerated the procedure if it's after the initial stick. Okay, there are always potential complications associated with IV therapy, and they're similar in children and adults both. However, some aren't as common in children, and then others are more frequent in children. So the common complications associated with IV therapy in children are infection, infiltration or extravasation, fluid overload, and allergic reactions. Phlebitis and emboli can occur, but they're not nearly as common as they are in adults. Infection is the first complication. It can occur at the insertion site for several reasons. Improper cleansing before the venipuncture, contaminated equipment, disruption of the occlusive dressing that allows bacteria to enter the area, a moist or wet dressing that encourages bacterial colonization. Those are typically the reasons. Infection sites are usually local and they are red, warm, and have edema in the area. The child may also develop a fever. Again, the importance of vital signs in children. Septicemia is rare, but it can occur if bacteria enter the bloodstream, especially in children who already have a compromised immune systems. You can usually prevent IV site infection if you use strict aseptic techniques, provide the safeguards, and prevent the child from playing with or removing the dressings, and frequently monitor the dressing and change them as soon as they become moist. Those are the most important things in preventing infection in a child's IV site.